Thank you, everybody. It's my pleasure to be here again at another wonderful World Medical Innovation Forum. Each one seems to top the next one. And it's my pleasure to have Dr. Jeff Balser from Vanderbilt Medical to join us as well. Been a real leader over the last decade in developing Vanderbilt into what it is now, one of the most dynamic periods of growth for the health system. And it's quadrupled its net revenues and continues to expand its footprint throughout the Mid-South. And this rate of growth is really incredible, what you guys have been able to do, but is it sustainable? And what are the lessons that you have for other health systems, other academically medical-driven innovation centers that has really been built up around Vanderbilt in Nashville and created one of the great centers of medical innovation in this country? What are your lessons for others out there?
Sure, thank you for those nice words. And I guess I would say kind of two things. And one is, and they're both a little bit external to the academic medical center. We have benefited, especially since 2015, from two phenomenon. One is the incredible population growth in the Southeast. Many major cities around the country are stagnant or shrinking in terms of population, but to be doing healthcare and specifically to be managing hospitals in an environment that has rapid population growth is very helpful in growing net revenue and in growing market and footprint. So we've benefited from that in Nashville because Nashville's been on, as many of you know, a huge growth spurt for the last decade. The other thing we've benefited from at the same time is a different governance structure. Unlike independent not-for-profits and certainly public hospital companies, most academic medical centers are owned by something. In most cases, that's a university. And increasingly, academic medical centers are the largest constitutive part of those universities. And I think what we began to understand in the early 2000s was that the needs, both from a governance standpoint as well as a financial standpoint of a large medical center, are a little bit different than that of a university, and we were inhibiting one another in terms of our ability to focus on mission and grow. For example, and this is relevant to banking, most medical centers have more leverage than most universities. Top research universities tend to run with AAA bond ratings, whereas medical centers like to be A, but don't need to be AAA. And so those kinds of differences were really clamping us and keeping us both from achieving our goals. And of course, many others having our own legal teams, having boards that focused on our needs and were nimble enough to make quick decisions that were important in our market. All of those things just get a lot easier in an independent structure. So our spinning out of the university and becoming independent was both helpful to the university and to Vanderbilt Medical Center, and a lot of the growth you've seen from us has been since that restructuring.
Can you talk a little bit about contrasting maybe the Boston and Cambridge model with the universities you have here versus what you're seeing in Nashville with the growth and the innovation there?
There are parallels, frankly. First of all, it needs to be said that when we were trying to figure out what to do with Vanderbilt University Medical Center, we came to Boston and visited the medical centers here, and actually in many ways mimicked the structure that Mass General Brigham have to Harvard. Vanderbilt University still owns and operates what we call the Little Red Schoolhouse, the medical school that gives degrees to students, but everything else, the research, the physician employment, and of course the hospitals, sits under the medical center and is separate. And even though Mass General Brigham and Harvard have different names, the structures and what's inside the two constitutive parts is pretty similar to what we designed. And it was a little hard to argue that's not been a successful model. I think by all measures it has been. So that's one parallel. The other parallel is we haven't had the kind of biotech growth in Nashville that you guys have had in Boston. On the other hand, we've had dramatic healthcare services growth. So we've had growth in a kind of a parallel healthcare sector that in some ways resembles what's happened with biotech growth in Boston and Cambridge. And that has been a huge boon for not just Vanderbilt Medical Center, but HCA and the Ascension system and the other hospital companies that have grown up out of Nashville.
That's great. Can you talk a little bit about your growth in Tennessee and in the region as well? Because that's been a big effort of yours as well over the last however many years, and seems to be a continuing trend in additional acquisitions. Talk a little bit about your growth strategy.
I would say that initially we were not as aggressive at buying hospitals as some of our peers. We went out and tried to make friends. We created what we call the Vanderbilt Health Affiliated Network, where we had affiliation agreements with lots of hospitals and health systems, almost all not-for-profit health systems in the state of Tennessee. And the idea was kind of to have the best of both worlds. We weren't having to take on the management of those entities, but at the same time, we could work together productively because we primarily provide specialty services that they needed. The problem with affiliation agreements is it's a little bit like dating. And it turns out when people date, they sometimes cheat. And we experienced that and realized that in the end, folks operate in their self-interest, and so we actually realized 5 or 6 years ago that we would need to acquire some hospitals, which we then did, and we have 3 community hospitals around us that we fully own, and we joint venture, partly own another hospital. All of the hospitals we've purchased are within an hour's drive of the main chassis of the medical center, so that we can actually build up specialty care at those hospitals with our own doctors initially. And that's hugely important because our goal is not to suck patients out of the community hospitals we acquire. We are full. Like the Mass General Brigham emergency room is so full you can't imagine how it could be any fuller. We have that problem in Nashville, Tennessee. On any given day, I'll have up to 100 patients waiting in the emergency room for beds. So we want to tune the acuity of the region by having actually more patients that are lower acuity stay in those hospitals. All we want is the heart transplants, right? Which is not a huge number of patients. And so the way we accomplish that is by actually building up the specialty care in those hospitals. So we've seen the hospitals we've purchased 45 minutes away from us go from an average daily census of 50 patients to 150 patients, because now they have a cancer center at community level. Now they have, cardiology, even up to the point of maybe catheterization. Those kinds of what I would call low to medium level acuity services can be built up, and we can keep more patients out of the core chassis, which is the really highest acuity and frankly most expensive chassis of our system.
And how big do you kind of see it growing? I mean, where's the
end point
of that?
But I guess all I would say is I can see the concentric circles growing, but our strategy has not been to go off to Florida and buy a hospital, because I can't reconcile that with the strategy we've developed. And we really feel that the value of the system is to be able to bring direct influence of the system to the hospitals we acquire and joint venture with. And it's today in 2026, it's really hard to do that across a long geography, especially given I think of Vanderbilt as a physician company that owns hospitals. And it's hard to export physician expertise. It's hard to get a whole bunch of doctors to move to another location. And I think that's the struggle that many health systems have encountered in trying to purchase hospitals that are far-flung. It's a much tougher road to success.
Yep. Shifting gears a little bit, obviously this year has been a really dynamic and also challenging year from a
Has it really?
research perspective. And you've gone through some changes and announced some significant changes around reducing your workforce in the face of federal cuts, research grants that have been dialed back. Talk a little bit about how you came to decide on what you wanted to cut, how you wanted to make these changes, and how to kind of stay true to the research mission that you also have at Vanderbilt.
Yeah, thank you for that. So like Mass General Brigham and some of the other big systems here in Boston, research is a core part of our mission. We're the 5th largest NIH funding recipient for medical schools in the country. So out of our expenditures on an annual basis, if we have $8 billion in healthcare expenditures, we have $1 billion in research expenditures. So it's a big part of our portfolio. What we did in, you know, it was in the media, we laid off 650 people back in the spring. And that was for 2 reasons. One is we were having a huge slowdown in funding from the NIH, as all institutions experienced. We didn't lose a lot of grants, but the funding was just dramatically slowed of awarding, you know, new grants that we knew were eventually going to get funded. And the other issue we had in Tennessee was a huge delay in the receipt of our directed payments through Medicaid. And so we kind of had it coming from both sides, along with some reduction in our 340B revenue that was also happening because of some regulatory issues that came along with all that. So I kind of felt like the responsible thing to do was for us to begin cutting, but not cutting to bone. So what we tried to do was pare back research programs that had been unsuccessful for some period of time in achieving outside funding. Honestly, it would be great to support those longer, to give them a little more time, but we just couldn't do it, right? So we had to be a little bit harsher with those decisions, but it's not like we were going in and removing heavily funded research programs. I would say the same thing about the healthcare platform. What we did was cut back on some nice services that patients liked but were not paid for by insurers, but not a huge number. So I think many healthcare systems approach things in that way. I would say that then in the last quarter, since July 1st, things have improved a little bit. Now we're getting a little bit better. We're actually getting pretty good flow of funding through the NIH. That pressure has been relieved somewhat, although we're still worried about cuts to the indirect cost rate. And I would say that some of the pressure on Medicaid directed payments, at least in the state of Tennessee, has been relieved. We've now received those payments. So I'm not sure where this goes. You know, the budget discussion that's going on in Washington, D.C. right now could be anywhere from a non-event for America's teaching hospitals to a complete and utter disaster. And I'm really, to be honest, not sure where in the spectrum we land. The optimistic side of me says we've taken the lumps we're going to take and maybe we move on, but I would say that's with extreme caution, because there are some things like hospital-based payment that would really hurt us in our ability to cover all the missions from teaching to research, as well as if the NIH indirect rates settle into something that's a whole lot less than we receive today. I think that's going to cause us to relook once again at what we have to do to right-size our economic base so that it's sustainable. So I would say right now we're sustainable, but we're cautious about what may be coming next.
Yeah, a lot of uncertainty, that's for sure.
Yeah.
Let's switch gears a little bit and talk about some of the critical research you all have focused on. You did form a wholly owned subsidiary, Nashville Biosciences, and established the Alliance for Genetic Discovery with several pharmaceutical and biotech companies. And today you house the nation's largest whole genome DNA depository. What have been some of the immediate benefits from this, and what is your vision for where you take it going forward?
Yeah, thank you for that. The story of that DNA repository goes back really to 1995 when someone named Bill Stead, one of the fathers of, I guess you would call him a grandfather now, of healthcare informatics in this country moved to Vanderbilt to set up the nation's first department of biomedical informatics. And Vanderbilt Medical Centers had a health record, an electronic health record that was fully deployed since the late 1990s, which is a long time. So in the early 2000s, we actually, through a lot of effort, figured out a way to de-identify that health record and marry it to DNA collection, which nobody was doing at the time. And we were a big outlier at the time, but we started collecting 20, 30, 40,000 DNA samples a year and marrying those to what I like to call an avatar health record. And that repository's been growing over the years to the point now it's close to 400,000 DNA samples married to health records that on average are 11 years long, and some of them are 20 years long. Pharma has become really interested in that resource. It's not, I would like to be able to say it's the largest whole genome sequenced resource in the United States. It turns out that the All of Us repository, the nation's precision medicine initiative, is bigger than that. The good news for us, though, is that also sits at Vanderbilt because we're the principal investigators for that effort as well. And the two repositories sit side by side, and we build tools that operate on both of them. But pharma sees this as an enormous tool for drug discovery, target discovery, as well as off-target side effect identification. And what 8 or 9 pharmas did was come together and say, hey, wouldn't it be better if instead of just having the coding sequences, what we call exons, like what you get done by 23andMe, if instead of just having that, what if we had the whole genome? And for those that don't think about DNA every day, the exons you get from 23andMe is 1/1000th of the whole genome. So what you're used to getting is the 1 yard line, this is the whole football field. And this is so new to science to have whole genome sequence at this scale that we don't even know yet what kinds of signals that are going to be important for health and disease are in the whole genome sequence. So it took a year and a half. The pharma companies came together, and the cost of doing this was well north of $100 million. And the pharma companies agreed to have this sequencing done in Iceland at the Decode facility. So we've been shipping DNA samples to Iceland for the last year and a half. It's all finished as of a few months ago, and now we're starting to mine it with those companies to look at what are the new signals that are regulatory sequences that really determine how someone responds to a drug, whether they're likely to get Alzheimer's disease. All those things we'd like to better understand are going to be a rich discovery resource. And we're excited about being in the middle of it, and we think that's going to make Vanderbilt and Nashville an even bigger attractor for biotech and pharma discovery.
That's great. Another big issue that we've heard, the theme throughout a lot of the sessions, is around workforce. You kind of brought this up already.
Yeah.
Obviously, you need researchers, you need physicians. It's such a key component, even additional skilled staff. How are you dealing with that at Vanderbilt? And there's so many challenges now, and down the road, trying to build, but also trying to, as you found out, there's kind of a balance there. You have to figure out what's the most appropriate levels for what you need.
I think it is fundamentally the question, actually, because we find ourselves with nationwide healthcare shortages in everything from doctors to sterile processing technicians. And we find ourselves in a situation where at the same time, those shortages are causing the cost of labor to skyrocket. And what we're doing is saying it's more expensive to deliver the care. We've got to pass that on to insurers, who are then passing it on to the nation's employers, who are trying to deal with 10 to 12% annual increases in their benefits costs for their employees, which is not sustainable. So we're in this negative feedback cycle. Short term, sure, academic medical centers are in a great position to build programs with community colleges to build our own workforces. And frankly, that's what we've all started to do coming out of COVID. We have a sterile processing training program that we've built with a local community college so that we can get more of our own people. But that's not going to solve the huge problem that I just mentioned. And I actually think that what healthcare needs to do and what academic medical centers are equipped to start helping us think through is how do we deliver healthcare to people with a lot fewer people? Let me tell you what I mean by that. I don't mean that we're going to remove you from the relationship, the direct person-to-person relationship with your healthcare provider. But I shouldn't think we need to use that as an excuse not to look at the entire system behind that interaction and look at how many people are involved. I'm really informed by a visit I did right after COVID. One of our donors at Vanderbilt made a whole lot of money because he builds cardboard boxes and he was selling them to Amazon. Wish I were him. And so he took me to his factory in Chicago. And it's the size of a football field. And I walk into this place, machines going crazy, building these boxes. There were 5 people in the factory, right? I mean, we would have had 10,000 people in that space. And I would argue that healthcare has never been forced through the direct competitive forces that happen in other industries to figure out how to do business with fewer people. We've just not been pushed that hard. We've had an insurance system that paid us for a long time, no matter what we did. We just have to be honest about that. While other industries, like banking, like many manufacturing industries, had to figure out how to do things without a whole bunch of people. So now we're there, right? Now we have to figure out and take an ambulatory environment, right? Is it really necessary to have all of those people sitting at desks checking us in? The airports have figured it out. You do everything at a kiosk, and there may be a few people around for those of us that are too clumsy to figure out the kiosks. I would be one of those. But honestly, we have to get serious about this. Vanderbilt has rolled out a program that we're trying this in our 100 Oaks Patient Care Center, which is a converted shopping mall with 400,000 square feet of clinics. And for the longest time, we had an army of people lined up at front desks checking people in. Well, now we have an app, which is derivative of the Epic healthcare app, but it's our own because we love programming health IT. And that app now takes all of your information, your insurance information. It asks you all the questions the doctors need to know before you come into the clinic. You do that at home. You can do it sitting in the car before you come in. And then it even has you press a button when you arrive on your phone at the clinic so the clinic knows you're there. You don't even have to go to a desk. Now, that's not the whole story, but it's a piece. And yeah, some people say to me, I really miss the warm, fuzzy interaction I used to have with the person at the desk. I really like that person. Yeah, I agree, that was great. But we just had to lay off 650 people that we really like. And that's not good either. And so I think we're finally at a time in healthcare we're going to have to start making some hard choices about what human interactions are really important and what we could learn how to do with much better robotics, much better automation, AI, frankly, what avatars can do and are already doing in many industries to handle simple questions instead of people. That's going to become a huge deal, I think. So it's a long answer to a short question.
No, but there's a lot in there. There's obviously a lot in there. And wrap it up with one last question on, I guess I'd be remiss being from DC not to ask about reimbursement.
Yeah.
And this kind of feeds into just what you're talking about, that there is a lot of waste and efforts to try to cut some spending in a lot of different places. We're obviously facing it and dealing it with Medicaid cuts that are upcoming.
Yeah.
You mentioned site neutral payment reforms and 340B potential reforms, and we can go down the laundry list.
Where's the thing that's going to increase?
Yes.
Yeah, what?
That's exactly right. So maybe if you could just wrap it up and tell us,
Yeah.
how do you think about all of these pressures? And I didn't even talk about the commercial managed care pressures, but you alluded to that.
Sure.
They're dealing with some of these similar issues. How do you think about that on a go-forward basis?
Honestly, I tell our folks at Vanderbilt Medical Center that not a single line of revenue on a per unit basis is increasing or will ever increase in their lifetimes. So job one every day is to come in and figure out how to do more with less. And that's where all this discussion about automation and technology comes in, because we believe in academic medicine what we deliver to the public is incredibly important. Both the healthcare and the training and the research. The country depends on having us do all three of those things well, so having to cut any of them is terrible. And we've got to figure out how to innovate our way through this and deliver the products we need to deliver to the public far less expensive, because there is no revenue stream coming into healthcare on a per unit basis that's going to increase. It just can't.
Yep. Well, on that note, thank you so much, Jeff.
My pleasure.
We'll be watching you at Vanderbilt. A lot of dynamic things happening, so thanks so much.
Appreciate it.
Yep.